So I'll start. I said I've been asked to speak on anti-diabetic drugs and the bone health. So why today we're talking about drugs, or maybe when it comes to choosing an anti-oral or maybe an injectable anti-diabetic drug, that why bone health is so important. This is primarily because of the fact that type 2 diabetes creates a fragile bone phenotype where the fracture risk increases. And this is in spite of the fact that bone mineral density could be normal or maybe actually on the higher side. So I'll say that today there are two goals, or there is a dual goal, not only to ensure a dual glycemic control, but also to attain at least a reduced fracture risk, or the burden of fracture risk should not go up with any of these drugs. So let's see why diabetes is associated with greater risk for fracture, in spite of the fact that BMD may be on the higher side. I said it is per se because of hyperglycemia in diabetes. There are advanced glycation end products. There is an insulopenia and low levels of IGF-1 and mesenchymal stem cells maturation is also affected. So that leads on to reduction in osteoblastic activity. There is a cortical porosity changes which happen, and that leads on to impaired remodeling, contributing towards dense but little more fragile or brittle bone. So it is a paradox that with higher BMD, you are at a greater risk, and type 2 diabetes, many of them might have higher BMD, I told you. So today it is very, very important that we do a risk stratification, not based primarily on T score, but also looking into the entire spectrum of these patients. And let me tell you that today bone is also being looked upon as an endocrine organ because of the fact that bone, pancreas, and adipose, they cross talk to each other, and it is a bidirectional relationship. Osteoblast activity influences glucose handling through osteocalcin biology, while insulin or incretin pathways, I'll be discussing that, they can signal directly on the bone cells. So this creates a mechanistic rationale to prefer those drugs which are not only going to get good glycemic control, but also going to have at least a neutral or maybe a bone sportive effect. So when it comes to a prep frame for starting anti-diabetic drugs today, there are questions that whether that drug is going to change the BMT in toto, or whether that drug is going to lead on to a greater fracture risk, maybe by weight change, by mineral handling, or by hypoglycemia, or predisposition to falls. And I must tell you that there are complex pathways towards that. A drug can be bone anabolic, like insulin typically, but still the fracture risk may be very high because of predisposition for hypoglycemia and frequent falls. And drug may be biologically neutral many times, but still it may improve muscle strength, weight, and overall cardiometabolic value of that patient. So there are certain bone-friendly drugs which are going to be attractive anti-diabetic drugs. First one is, of course, the metformin. Metformin, we know, activates AMPK pathway. So it promotes osteoblastic differentiation cell lineages and can actually counter adipogenic draft or the shift within the marrow. And in various translational models, it has been seen that metformin enhances osteoblast specific transcription factor RUNX2. So there is going to be better mineral deposition, sporting a plausible bone benefit phenotype coming out of metformin therapy. This is how it works. It increases differentiation of osteoblastic cells, and all advanced glycation products go down. There is a down regulation of that. I told you through activation of AMPK pathway, there is activation of osteoblast specific transcription factor RUNX2. So overall impact is that there is going to be a better formation or remodeling of the bone when patient is on metformin. And this is being seen in all the meta-analysis which are available, that this could be a bone friendly drug. Coming to GLP-1 receptor agonists, which are very, very hot selling drugs today, we know that there are receptors on the bone as well as on muscle also. And again, it is going to be a multifactorial mechanism when it comes to usage of GLP-1 receptor agonists. Not only they have a direct signaling through osteoblast, osteoclast coupling, but also they work through independent or indirect pathway because it leads on to weight reduction. There is going to be improvement in insulin sensitivity, reduced inflammation, and overall improved physical function is going to be seen when it comes to GLP-1 agonist. This is how it works. It reduces primarily advanced glycation end products. There is going to be a positive impact on the BMD. It also regulates beta carotene signal transduction also. And with GLP-1 receptors on the bone, there is going to be a better activity of the osteoblasts, and overall risk for fracture through GLP-1 receptor agonist is going to be much lesser. And all the trials have shown that it is at least neutral on the bone. And evidence says that although most of the trials with GLP-1 receptor agonists are in terms of CV outcomes, not primarily looking into the bone outcomes, but they have shown that it is classically neutral when it comes to risk of fractures. And even exenatide post hoc fracture analysis, which was done, has shown that overall there is a bone safety which was available in that trial for GLP-1 receptor agonists. Once it comes to DPP-4 inhibitors, they are typically neutral, and what it does, it obviously increases the level of GLP-1 also, and glucose dependent insulinotropic polypeptide, which may further influence the bone, way we have seen with GLP-1 receptor agonists. And advantages that DPP-4 are typically weight neutral also, and there is a very very low risk, almost negligible risk of hypoglycemia, so that predisposition to falls or risk of fracture is not there with DPP-4. This is how DPP-4 works. It reduces accumulation of advanced glycation end products and leads on to osteoblastic activation. Through vitamin D metabolism also, it has a positive impact on bone remodeling, and there is a reduction in NPY and increase in GLP as well as GIP. So overall, there is a trend that it comes out to be a neutral drug in terms of predisposition for risk for fracture in the long run, and there is no hypoglycemia, no risk of additional risk of fall. So that is how this comes out to be a very very important drug when it comes to choosing a anti-diabetic drug in interests of those elderly patients who are otherwise at a greater risk for falls. Then of course insulin, typically it has a anabolic biology, but fractures are found to be on the higher side once it comes to usage of insulin. Insulin signaling is generally considered anabolic to bone, but then because these patients are at a greater risk for hypoglycemia, many of them they have a long-standing diabetic, might have peripheral neuropathy or greater risk for orthotic hypertension. So they are at a greater risk for getting fractures as well as falls. And mechanism for insulin proposes that it increases bone mineralization. There is an increased differentiation and proliferation of the osteoblast, and with synergistic effects with IGF-1, overall there is a class effect in terms of that it comes out to be a safer drug having a more bone safety. Of course, the risk I told you, because many of those patients, those who are ultimately on insulin, they are long-standing diabetic and they are elderly patient. They might have a lot of microangiopathy and macroangiopathy, and overall risk of fracture there might be on the higher side. So if you overall assess the database, insulin comes out to be, in terms of its mechanistic role, it comes out to be very, very safe. It is a bone safe drug. But of course, we have to be very, very cautious because the risk of nocturnal hypos and maybe nocturia at times is there. Those patients might have retinopathy, so they try to get up in the night, they might fall. So overall risk with insulin could be on the higher side. SGLT2 inhibitors, because they address mineral physiology, and of course they are neutral for any fracture risk. And the mechanistic considerations are, we know that these are sodium glucose co-transporters which can also shift phosphate handling. They also address to fibroblast growth factor 23 signaling as well as calcium balance in certain settings. So if you look upon SGLT2, not only it leads on to osmotic diuresis and there is a greater renal loss of sodium along with glucose, and there is also, I told you, increased phosphate reabsorption and increase in level of PTH and FGF23 is again on the higher side. So overall, SGLT2 comes out to be neutral to the bone. Of course, canagliflozin data in canvas has shown that there was a greater risk for developing fracture. So until unless an SGLT2 is absolutely indicated in interest of cardiorenal protection, these drugs ideally should be avoided in elderly patients, those who are at a greater risk by virtue of getting osmotic diuresis. They might have postural drop in blood pressure, and there the fracture risk may be on the higher side. So you have to balance the cardiorenal priority while using an SGLT2 inhibitor, and must make sure that these patients are not on loop diuretics, and you are at least able to keep them well hydrated and replete their vitamin D also, and use all fall prevention strategies in these patients, especially if these are older patients. Then there are drugs which can increase or may harm bone health, and it is typically TZs, which have a clear fracture liability signal mechanism. We all know that these are PPAR, gamma, Ignis. So there is going to be a shifting of mesenchymal stem cells towards adipogenesis. We know these lead on to adipogenesis redifferentiation. So obviously, bone formation or remodeling is going to be much lesser because of activation of PPAR gamma. So there is a reduction in bone formation, and there is an increased adipogenetic signal because of differentiation towards adipocyte. So that increases significantly the risk for developing fractures once patients are on TZs. And this is what was seen in ADOPT trial, that that has shown that especially in post-menopausal women, there was a very significantly higher risk of developing fractures in these patients. So when it comes to type 2 diabetes, especially those patients, those who are elderly or those who are likely to be osteoporotic, like older adults, or with prior fragility fracture rate or history, or chronic usage of steroids, or maybe exposure to steroids, or those who have low body mass index or lean mass is very, really less, there we need to be very, very cautious while choosing a drug like TZs. Once it comes to sulfonylurea, they are almost neutral when it comes to the direct impact on on the bone. But again, sulfonylureas, we know they increase the risk for having hypoglycemia, especially when it is being co-prescribed with the other drugs in elderly patient. So there we need to be extremely cautious because the risk of fracture with sulfonylureas may be higher, especially if you are aiming for a very tight glycemic control along with insulin or couple of other drugs. You need to reduce the doses of sulfonylurea. So there is a table to sum up all the drugs together. Metformin increases BMD, the risk of fracture actually goes down. So it is a very, very friendly for the bone. Once it comes to sulfonylurea, I told you, although data is not very large, limited data is available, but definitely there is going to be a greater risk, especially in elderly or frail patient or postmenopausal patients. Once it is SGLT2 inhibitor, they are almost neutral on BMD, but canagliflozin has shown a signal towards greater risk for fracture. DPP4 are classically neutral, like any other side effects of DPP4. So these could be good drugs, especially for elderly and frail patients. GLP-1 receptor agonists, they might little bit increase BMD, or they are neutral on BMD. There is no higher risk of fracture once patient is on GLP-1 receptor agonist. TZs are the one which are going to be extremely harmful, especially in postmenopausal women and elderly patients. And insulin, I told you, increases the risk of fracture and falls by virtue of more risk for developing hypoglycemia. So once it comes to the newer drugs like GIP dual agonist, of course we don't have too much data on that, but of course GIP biology may support osteoblast formation, but large weight loss, that itself needs to be considered because that may reduce the overall mechanical loading and the BMD. So we don't have still enough evidence on dual GLP as GIP agonist. So we need to be little cautious. And of course, with these drugs, there is going to be significant weight loss. Many of these patients, especially if they are more than 60, they are going to be sarcopenic. So that could also affect the overall BMD, and there could be little greater risk until unless we make sure that they have adequate protein, they do resistance exercises, we supplement vitamin D on the regular basis, and we put in place all fall risk strategies so that they are not at a greater risk for going for fall. And this is how sclerostin and bone they are connected with each other, because we know that elevated sclerostin signaling has been proposed as a contributor to low bone turnover in patient with diabetes. So we need to take this into consideration. And when coming towards the final option of choosing a drug, we must choose all drugs, especially I told you, postmenopausal women, elderly, frail patient, where there is already existing sarcopenia and they are at a little greater risk for fall. We may start with metformin in most of the patient. An alternative option in most of these patients be a DPP4 or GLP-1 receptor agonist because they are typically neutral. And of course, when it comes to choosing a drug in postmenopausal women, we should not use drug like TZs. And a fracture risk assessment today is going to be extremely important for every patient. Even if we advocate that every patient must ensure a 5 to 7 or 10% weight loss, again, we need to assess that what is going to be their renal function, how that significant weight loss along with sarcopenia, along with lean mass loss, is going to impact their BMD as well as their risk for getting fracture in the future. Thank you very much for your patience listening. And